Hello, this is EHJ Today. I'm Carl Svedberg from Gothenburg, Sweden. I'm at the ESC 2015 conference in London, and with me is Professor Gerard Elft from Paris, France, and Professor Lars Valentin from Uppsala, Sweden. We are going to discuss a study that Professor Elft has presented, the OPTIDUAL trial. Now, Gerard, tell us, why did you do this study?
Thank you. In fact, as you know, the optimum duration of dual antiplatelet therapy after drug-eluting stent remains very debated. So we're keen to do another study to try to demonstrate that on a background of aspirin, continuing clopidogrel for up to 48 months would be superior in reducing net adverse clinical events compared with 12 months of dual antiplatelet therapy.
Okay, so an important question. So how did you move ahead and organize? I assume it must be a fairly big trial then.
In fact, we have included 1,799 patients who received a drug-eluting stent, and 1 year later, in the absence of MACE, of bleeding, and if the medical doctor agrees, we have randomized almost 1,400 patients to receive clopidogrel or to discontinue clopidogrel.
Mm-hmm. And this was all done in France?
Yes, we had 58 sites in France.
Okay. Then what did you find?
In fact, what we found, extending the APT did not achieve a statistical superiority in reducing MACE, but there was a strong signal in reducing the MACE, the thrombotic events, even if we did not achieve statistical significance.
So what's a strong signal?
The signal is that with DAPT prolonging for up to 48 months, you will reduce the thrombotic events. There is a trend. We have fewer events, fewer myocardial infarction, fewer stroke, and fewer deaths with prolonging DAPT.
But it sounds this was not a clear. So you failed your primary objective, a superiority.
Exactly.
You were close, but
not so close. In fact, we have a trend. I cannot say more. We have a trend. What was also important, and we did not observe an increase in major bleedings. That was perhaps a surprise, because the rates are identical in both groups. We have 2% of major bleeding according to IHJ classification in both groups. So that's not very surprising, but it's of course we had selected a low risk population.
Okay, but maybe that's important as well.
Exactly.
So what will you do now in your practice based on these results, and what's the study group's recommendation or conclusion?
Of course, the answer remains very difficult. You have to decide on one case by case. We have, of course, the results of the large DAPT trial that have shown that you reduce thrombotic events, even though you may have increased bleeding. So it's still difficult, but perhaps if you can stratify the risk, if you can tell that the patient has a low bleeding risk, you may consider prolonging the APT. But of course, you have to be very cautious.
Okay. I think we'll come back to in the context also of the newer antiplatelet agents. But I would like to ask Lars Valentin, you have extensive experience from studies in this field. So what's your interpretation of these findings, Lars?
I think when this study was designed, there was a very important question, and the investigators were early, starting the study in 2009, when there was almost no knowledge about prolongation of dual antiplatelet treatment. And I think they should be complimented that they started an investigator-initiated trial with limited funding and with a network of investigators trying to accomplish this. However, I think it's very unfortunate that the trial was prematurely terminated because of limited funding and slow recruitment. And if you have an open label trial that is prematurely terminated, where the investigators also handle the database, there are always uncertainties about this. And so I think overall, the signal that the investigators see, it fits with the data in the big DAP trial with 9,000 patients, that prolonged treatment reduced ischemic events, but there were so few events, so it doesn't really add to bleeding, because it has convincingly been shown that bleeding is increased by prolongation of the treatment. There is also a concern in the meta-analysis about an increase in mortality. So unfortunately, we don't get much more than what we had before. So my reflections that I've commented on is that I think we need to maybe to rethink investigator-initiated trials. We can't afford to have failures, underpowered trials, too small trials where we have an important question that is not answered. I think there were two reasons for this. One is that this was a very low-risk population. There was only around 1% myocardial infarctions per year and 1% mortality. This is no big unmet medical need. There are patients here that have a higher medical need, and we should be able to identify those. So we need new tools for risk stratification and focus on patients with higher ischemic risk, and we need to know the bleeding risk. I think this goes both for the DAPT and the Pegasus trial, where we have similar event rates, very low event rates overall, and in order to be able to pay the cost for a new treatment, there must be an incremental benefit that kind of motivates the increased cost. I also had a second reflection, and it is that we need a better organization of investigator-initiated trials. We can't really afford to, in a national environment or even a local environment, design trials with an over-optimistic hypothesis, focusing on all comers, and then because of limited funding and competing trials have a slow recruitment. So I have compared this to the Swedish experiences with the registry-based clinical trials, where investigators seem to be able to include 60% of every patient. In this, the French centers here really recruited only around 1 patient a month, or maybe even less. So obviously there were many more patients out there not included, maybe because of limited incentives, limited funding. So I think we need another structure for investigator-initiated trials, European networks, an infrastructure, because it's really more or less unethical to perform trials that are prematurely terminated. We cannot expose the patients to this risk. So I am arguing in favor for be able to identify the target patients and an improved support for investigator-initiated trials, that the French investigators have shown that it can be done, but you need a better infrastructure.
Okay, so that's an important experience, and you should be obviously congratulated for setting out to do this. Shortly, would Lars touched upon the newer agents. Would that have any impact, with using newer antiplatelet agents with this knowledge, you think?
In fact, OPTIDUAL, there were only clopidogrel that was studied. So in fact, we cannot extrapolate at all. We have the chance to have the large Pegasus trial working on ticagrelor. And so what we can say that perhaps, of course, in the Pegasus trial, there is an increased risk of bleeding, but of course, ticagrelor is stronger than clopidogrel. So I think that it's very difficult for us, coming from the OPTIDUAL study, to make comments. It concerns only the clopidogrel.
Lars, a comment in that context?
Well, I think we need trials evaluating continuation of ticagrelor versus continuation with aspirin, and I think also in relation to I mean, clopidogrel is a generic drug. It's a cheap additional treatment. If you add an expensive additional treatment, I think you might even more need to focus on the higher risk population, because they both have a higher cost in relation to money, but a higher cost in relation to bleeding.
As you said. So there is more work for you and your colleagues in the network to do, and set out to try to do new similar efforts. Obviously there is more to know, or?
Exactly, I completely agree with Professor Valentin's comments. He's completely right. We have to improve the national network. We have to focus on the bleeding risk, the thrombotic risk, and to achieve newer results. I completely agree.
Okay, thank you for coming and letting us have these interesting thoughts about what we know and where we are heading.
Thank you for the invitation.
Thank you.